Hello, and thank you for joining this OncLive TV Peer Exchange. This program will feature expert panel discussions focused on the treatment and management of chronic myeloid leukemia. I'm Dr. Jessica Altman, Associate Professor of Medicine in the Hematology Oncology Division in the Feinberg School of Medicine at Northwestern University. Joining me today are Dr. Stuart Goldberg, Associate Clinical Professor at Rutgers University, Dr. Elias Jabbour, Associate Professor in the Department of Medicine and Division of Cancer Medicine at MD Anderson Cancer Center in Houston, Dr. Doug Smith, Associate Professor of Oncology at Hopkins University School of Medicine, and Dr. Neil Shah, Associate Professor in the Division of Hematology Oncology at the University of California, San Francisco School of Medicine. Thank you to each of you for joining us today. Now let's get started. First, going to start discussing genetic testing in chronic myeloid leukemia. CML, or chronic myeloid leukemia, was the first disease for which a unique genetic marker, or the BCR-ABL, was found. The Philadelphia chromosome is the hallmark of this disease. Therapeutic decision-making today is based on the presence of the BCR-ABL and targeting that abnormality. In addition, we now know that mutations can occur in the BCR-ABL kinase domain, and it can serve as a model for adjusting therapy and, in fact, hopefully developing more precise medicine. It's important for clinicians to understand how and when to conduct mutational analysis testing and then what to do with the results once we have them. So I have a series of questions for my esteemed panel. When should you choose to do genetic testing in a patient with chronic myeloid leukemia? Is this something we do when we first are seeing a patient with newly diagnosed CML?
Well, when the patient comes in, the first thing that we're going to do is make a diagnosis for CML, and that's going to be doing a bone marrow or doing something to prove that the patient really does have the Philadelphia chromosome. So a bone marrow with cytogenetics would be part of my initial workup, and I'll also send a baseline PCR from the peripheral blood for the BCR-ABL fusion protein, so I can first off establish that my laboratory can find that marker and then use that same marker, because I've had patients who are Philadelphia chromosome positive by genetics but don't have the marker in the blood. And then once I have the baseline, I can then also use that down the road to make sure that my patient's responding to treatment. So up front, it's important to get both tests.
I think that one thing that's important to recognize is the second half of that, which is there's also certain types of genetic testing we do when we're looking for trouble, and we're looking for mutations or changes in the Philadelphia chromosome as well. And you know, Neil, you're an expert in this area of looking for mutations and things. Are there times when that's indicated?
Yeah, I'm occasionally asked whether it makes sense to look for these before even starting therapy, and that's a great question, but one would need a very, very sensitive test. And of course, as tests get more and more sensitive, there's a concern that it may even be picking up an artifact. So my answer is essentially no. There's no reason to do a mutation test prior to therapy. It's a different story if a patient has progressed from chronic to accelerated or blast phase on TKI therapy. The important thing to realize is that there needs to be selective pressure on the disease to really enrich enough for a resistance conferring mutation that can be detected by most of the commercially available tests. I want to follow up on one thing, though, that Stu said that I think is really important. And I've had also these rare patients, probably only 1 or 2%, but of course all of us here have treated, dozens, if not, over 100 patients with this disease. And we do know that somewhere around 1 to 2% of patients will have an atypical BCR-ABL transcript simply because of where the chromosome breakpoint occurs. And this is important to know because if you don't check for it at baseline, you will be falsely lulled into thinking that the patient is undetectable the first time you do check, and that undetectability is reflecting a deep molecular response when in fact there could be no molecular response whatsoever. So that's a really important thing to test at baseline.
Neil, I want to follow up with you about the mutations. You mentioned that we check the mutation at time of failure, which we all agree on that. At the ASH meeting, there are a lot of presentation about deep sequencing or next generation sequencing. Are these all routine now in our practice, or shall we just do the direct sequencing, the Sanger technique, with the limitation of the sensitivity?
Yeah, I mean, I think with the nice thing about Sanger sequencing is that it has been pretty well validated. I think we all believe clinically that if you see a resistance-conferring mutation with the limited sensitivity of Sanger sequencing, or on the order of about 20%, then you can be confident that that mutation is playing a role, some role in the resistance. So in addition to checking in any patient who's evolved true progression to accelerated or blast phase, it's recommended, of course, to check in any patient who's lost either a hematologic or cytogenetic response in the chronic phase. And similarly, for any patient who has had a substantial, by substantial I mean maybe 10-fold or 1 log increase in the BCR-ABL transcript level. Now, it's important to realize that a patient who's not adherent with therapy may have such a rise, and so it's always important when we're looking for mutations to take that opportunity to also ask about adherence. But coming back to your question, I think that these newer, more sensitive tests are very promising. We do believe we should be able to detect, you know, resistance-conferring mutations. But I think if we have a phenotype, meaning if we have like a loss of response, the Sanger sequencing should be enough to tell us whether a mutation, what the dominant mutation is and what to act on. Now, what will be really interesting to find out is whether some of these low-level mutations that you may find with these next-generation techniques are actually going to subsequently drive relapse. I think the early data does suggest that that will be the case.
So that's what we call compound mutations, like you have multiple mutations and you suppress them with one drug and then they progress later on. And that may trigger the change in prescribing TKIs. We know from the data available so far that ponatinib may be more potent inhibiting compound mutation than other TKIs.
I think, well, we know that ponatinib is certainly a very potent inhibitor. We know that it's active against all single kinase domain mutations. As far as its activity against compound mutations relative to others, I mean, I think you have to take this, I think the number of, so compound mutations by definition are when you have 2 different mutations on the same strand of DNA. And I think that there's an enormous amount of complexity that's added when we have that possibility. And people have not yet, you know, created all possible compound mutations that could arise in sequential therapy. So I don't know that I feel entirely convinced that any one drug is better at treating compound mutations, but I do think that since ponatinib starts off with the advantage of not being vulnerable to any single mutation, that it makes sense that it would have, you know, the lead on potentially suppressing all compound or a greater number of compound mutations. One important thing, though, to realize from the Sanger sequencing is that it doesn't tell you whether or not you may detect 2 mutations. One can never be sure that those are on the same strand versus in separate clones, and that could have enormous ramifications for sensitivity to the next therapy chosen. But just to add one last scenario in which it's recommended to test for mutations is in patients who don't initially meet a treatment milestone, you know, who have primary resistance, so they don't have, for instance, a complete cytogenetic response at 12 months. Technically speaking, you know, there's a 3-month milestone in some of the guidelines. I think it's highly unlikely that one is going to be able in only 3 months to select for a dominant mutation. But nonetheless, it's probably little harm in asking. As far as what we